Hi there, my name is Wesley Eiley. I'm doing a presentation on heart failure, and this is for nursing students and new orientees on the cardiac unit. So objectives, so by the end of this presentation, the learner will be able to define what heart failure is, identify signs and symptoms of heart failure, verbalize causes of heart failure, and explain various treatments for heart failure. So what is heart failure? Heart failure is a term used to describe the heart's inability to adequately pump blood and oxygen to the rest of the body's vital organs. So here you can see the right atrium, the right ventricle, which pumps deoxygenated blood out to the pulmonary artery, which goes out to the lungs where you take a breath, and that now oxygenated blood comes back into the pulmonary vein, into the left atrium, out to the left ventricle, out to the aorta, to the rest of the body. So if there's any compromise in the heart's pumps, such as the valves, the muscle here, if there's any kind of arrhythmia in the electrical system of the heart, that can cause symptoms of heart failure, which we will talk more about. So some of the causes of heart failure. Coronary artery disease. So if the heart's not getting good blood flow and oxygen through the arteries that supply blood to the heart itself, there will be some abnormalities in the way the heart pumps and squeezes. Hypertension, diabetes, valve malfunction. So if there's any kind of stenosis or regurgitation, that can cause heart failure. Stenosis meaning narrowing of the valve where it's completely closed off, and regurgitation meaning the valve is completely opening and blood is now leaking back into the heart, which can cause increased pressures in the chambers of the heart, which makes it harder for the heart to pump blood out to the rest of the body. Cardiomyopathy, which is some examples here. You'll see there's a thickened heart muscle here and a thin heart muscle there. So there's different types of cardiomyopathy, and both of these aren't good. Cardiac arrhythmias, as I discussed earlier, if there's fast rhythms such as AFib, that can cause symptoms of heart failure because the heart doesn't have a normal rhythm contraction. So blood will tend to pool in the chambers of the heart and cause symptoms of heart failure. Also, restrictive lung disease can cause heart failure. If there's any kind of restriction or inflammation or tightening of the airway, it makes it harder. The pressures increase in the lungs, which makes it harder for the heart to pump blood out to the rest of the body, into the lungs, is what I meant to say. So diagnosis. So in order to identify heart failure, there is two-dimensional echocardiograms, which they can do. There's transesophageal echocardiograms, which is when they go down the esophagus, and they look towards the top and backside of the heart. That gives them a good visual of the chambers of the heart and all the valves. They can do 12-lead EKGs, which is you hook up all the monitor patches to the patient, and you can look at the electrical system going through the heart, and you can see, sometimes you can see if there's left ventricle hypertrophy, left bundle branch block, right bundle branch block, and you can see arrhythmias as well, which can cause heart failure. Also, anterior and posterior chest X-ray would be great. That can show cardiomyogaly, infiltrates, pleural, and pericardial effusions, which is some side effects of heart failure. Right heart cath. So they go through the vein. They can go through the right groin there, up through the inferior vena cava, and look at all the pressures in the right atrium, right ventricle, and the pulmonary wedge pressure when going in there with the catheter. If they're doing a left heart cath and they're looking at all the arteries, they can actually do a left ventriculography where they go up through the aorta and down the aortic valve, and they can inject a contrast, and that will show how much blood the heart is pumping out with each contraction, and that'll show them the left ventricular function of the heart. And they're able to identify the EF, which we'll talk about here. So heart failure with reduced ejection fraction, which is how much blood the heart is pumping out with each contraction. It's never 100%. Normal is about 6 to 65%. And one classification of heart failure is when there's an EF of less than 40%, and that's systolic dysfunction. The other type of heart failure is with a preserved EF, but there is a diastolic dysfunction with an EF still greater than 50%. So sometimes people think just because an EF is 65%, that means the heart is good. Not necessarily. What was I going to say? So when the heart doesn't relax, it's not able to fill up with a lot of blood. And the way I explain it to students is, you know, say the heart pumps out 6 milliliters out of 10. That's 60%. And then the next person pumps out 60 milliliters out of 100 mLs. That's still 60%. They're both 60, but obviously the second one is pumping out more blood than the first one. So if the heart's not able to relax and fill up with blood, it's not going to pump out as much blood with that. So that's what diastolic dysfunction is with a preserved EF. So some symptoms. According to Evans, heart failure can present in an individual with signs and symptoms such as shortness of breath, fatigue, weight gain, nausea, edema, weakness, cyanosis, tachycardia, and tachypnea. Other symptoms could be elevated biomarkers such as NT-proBNP, or the regular old BNP lab values are another way for healthcare providers to identify heart failure and treat it adequately, as changes in fluid status and weight gain are not always an accurate indicator of heart failure. Sometimes there's inaccuracies of the weighing machine, so you can weigh somebody in a bed, a chair, a regular old stand-up scale. Sometimes you can look at someone's heart failure just by seeing how much fluid they're taking in and out, and sometimes that's not accurate as well because either they're not measuring or they're incontinent, things like that. Hyponatremia is another symptom of heart failure. So when your serum sodium levels drop below 135, that could indicate heart failure, because if you think about it, heart failure is when you retain fluid. And when you have more fluid on your body, that tends to dilute the sodium levels, which causes hyponatremia. So you can trend those levels to see if it's getting better or worse. So what left-sided heart failure looks like. You could have restlessness, confusion, tachycardia, dyspnea, fatigue, cyanosis, tachypnea, blood-tinged sputum, wheezes, crackles, cough. That's all signs of pulmonary congestion, elevated pulmonary capillary wedge pressure, things of that nature. So there is a difference between left and right-sided heart failure, which we'll see here. So right-sided heart failure, you can have symptoms of fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, and you may have some lung issues, distended jugular veins, anorexia, complaints of GI distress, weight gain, and dependent edema. So the treatment for heart failure. So the first thing to do is to treat the underlying cause. So say the cause is from ischemia or myocardial infarction. You know, you had a heart attack, and because of inadequate blood flow to the arteries, your heart isn't pumping that well. So we can try and do a percutaneous coronary intervention, or try and do a CABG procedure. Increasing the blood flow to the heart can help the heart pump itself. So we can start there and then check an echo in another 3 to 6 months to see if there's any improvement. Next thing, if somebody has a pacemaker, say they have a dual chamber pacemaker, and then over a few years their EF tends to drop to less than 35%. Sometimes we can upgrade the pacemaker to a biventricular pacemaker. So instead of having a lead in the right atrium and right ventricle, we can also add an extra lead to the left ventricle, which will help that EF. We can try things, so if somebody's in AFib, obviously they're not having a regular contraction and they're not able to pump out as much blood, because when somebody's in AFib, that atrium is just quivering and you don't get that atrial kick. So a way to fix that, the most non-invasive way, is medications. If that doesn't work, we can try cardioversion, which is where it's like a controlled shock. We could do an ablation, which is when they go up through the groin, through the vessels, and they can burn or freeze that irritated spot of the heart and cause a scar, and that will hopefully prevent fast arrhythmias from occurring, which can cause heart failure. Other things we could treat, so if somebody has a valve disorder like we talked about earlier, if it's stenosed or they're having regurgitation, there's sometimes options such as a surgical valve replacement with a tissue valve or a mechanical valve, or most recently, they've come out with transcatheter valves. So instead of taking out the old valve, they simply inject a new valve in through the vein and go up to the heart, and they open up the new valve in place of the old one. If they're not able to do open heart surgery, there's another thing called a clip, which is when they also go through the vessel and they can sometimes fix the regurgitation valve causing heart failure. And just to touch on some medications to treat heart failure: angiotensin converting enzymes, ACE inhibitors, ARBs, beta blockers, loop diuretics, hydrochlorothiazide are all types of medications people are treated with for heart failure. So yeah, the ACE inhibitor and ARBs, what they tend to do is they, in a way, dilate the vessel, so it takes some of the workload off the heart. In addition, they can help prevent any kind of remodeling of the cells in the heart. A beta blocker, so a lot of people that have any kind of coronary artery disease will be started on a beta blocker. What it does, it prevents the sympathetic nervous system from happening, and it kind of relaxes the heart, and it makes it easier for the heart to relax and pump out more blood to the rest of the body. The other diuretics here on the bottom, they focus on excreting sodium and water, so they help get the fluid off the body, which also helps make it easier for the heart to pump. I just thought it'd be interesting to include some images here. So this is what the cardiologists look at when they decide if somebody's in heart failure, if they need valves replaced, if they have cardiomyopathy, things like that. So you will see here in picture A, that is a normal tricuspid valve. Here in B, this is actually a bicuspid heart valve. And here in C, this is actually a calcified heart valve. So these last two valves, over time, you would have to do an intervention and get those replaced, because the bicuspid heart valves, those leaflets tend to get calcified and they can get narrowed and cause increased pressures in the chambers of the heart. Calcification also can build up on those leaflets and cause them not to work. And then here's a picture of the heart, and here on the left is a picture of a heart with cardiomyopathy versus a normal heart here on the right. So you can see there is a difference that is quite easy to see between the two. And there's my references. And I did do a small test on this, and I got a reading level of a 9th grade, but you know, because of there being many bullet points and not so many sentences, I feel this may not be as accurate. I feel like it would be a lot higher reading material, or level, I guess you could say. And that is it. Thanks for listening.